Good morning, everybody. Good afternoon. Good afternoon, everybody. Welcome to all of those of you from around the world on our IGI Zoom room and on Facebook Live. My name is Professor Hisham Mahana. I'm the director of the Institute for Global Innovation and an academic head and neck surgeon here at the University of Birmingham. The IGI is a signature institute for the university. We aim to inspire and deliver world-leading multidisciplinary research that finds solutions for the world's most pressing challenges. And we do that by bringing together teams of researchers from several disciplines, each of the teams looking at a specific challenge. And our main challenges are gender inequality, transnational 21st century transnational crime, resilient cities, safe and reliable water, clean air, aging and frailty, and antimicrobial resistance. The COVID-19 pandemic is undoubtedly one of the biggest challenges the global community has faced. And our research teams have had a key role and are having a key role in the fight against it. Examining its impact on all aspects of our lives and finding solutions for those challenges that are arising. And so we've started a series of online events, this being the first one, called Living with the Pandemic, where we bring together panels of our experts who give a short talk each on their research and perspectives on different aspects of living with the pandemic, followed by a chance for you to ask questions. There'll be 3 10-minute presentations. I'm pretty strict with time, so, and that's really to allow you 20 minutes to ask questions that you can send us through your Zoom room Q&A function and through Facebook Live. So please post your questions and we'll endeavor to answer as many of them as we can. Just to say that Zoom this morning, for our luck, Zoom had a message on their system saying that they were experiencing capacity issues today. So if you're having any problems, please join us on Facebook Live. The details were in the invite that we had sent out. We've got a really great lineup for you today. And so I'd like to welcome our speakers. But first, I'd like to welcome Professor Dominique Moran, Deputy Director of the IGI, who's my co-chair. So excellent. Thank you, Dom. Dom will take over if I drop out or I pass out. And we'll be selecting some of the questions that you sent through as well for asking our panel. And so to our speakers, our first speaker is Professor Justine Davis, who's Professor of Global Health here at the University of Birmingham, and she leads the frailty and aging theme of the IGI. Justine's work focuses on improving access to quality health systems in sub-Saharan Africa and ensuring that the research results are meaningful and are translated into policy. So Justine, hello. Our second speaker is Professor Stefan Kraus. Stefan is a professor of, now I have to say this with a lot of care, eco-hydrology and biogeochemistry. You don't say that when you've had a few drinks. And he leads our water challenges theme for the IGI. His work focuses on the fate and impacts of pollution in intensively used landscapes, particularly across the global south, and especially how that's affected by environmental change. His research includes a lot of innovations in environmental sensor networks, smart tracers, and numerical modeling. And last but not least, our third speaker is Professor Adam Cunningham, who's an academic based in the College of Medical and Dental Sciences at the Institute of Immunology and Immunotherapy. Adam is part of the vaccinology and immunomodulation theme in the college, and his research primarily focuses on how immune responses develop to vaccines anti-infection and how they impact on host immune systems. So without further ado, over to you, Justine. Thank you.
Thanks very much indeed, Hisham. I'm hoping everybody can hear me, and I'm hoping everybody can see my screen. Please shout if you cannot. Nobody's shouting, so I'm presuming this is fine. So I'm going to talk about living with the pandemic. It's a general introductory talk, which is really setting the scene. As Hisham's kindly said, my work focuses on sub-Saharan Africa, but the work that I do is pertinent to many other lower and middle income country settings. Before I actually get into the meat of the talk, I'd like you to just think about the history of the settings in which I'm going to speak about. These steps are the steps which the slaves last walked down when leaving Sierra Leone, and the slave ships would take them off from the sea there to their new and horrendous lives. So whenever you hear about lower and middle income countries, it's worth thinking about the colonial past and the influence that that has had on them. So I'm going to talk about epidemiology, prevention and treatment. And as I say, this is very top level overview talk. I do a lot of my work in Sierra Leone, and I'd like you to focus on this picture here on the top left. You'll see a very different view of that at the end of this talk. But Sierra Leone is one of the least developed countries in the world. This is Crew Bay. It is one of the largest slums in Sierra Leone. And it is basically a township built on wastes and rivers of plastic. And that's where a lot of the work that we do in sub-Saharan Africa, whether Sierra Leone or elsewhere, focuses. So to epidemiology. So the first case in sub-Saharan Africa was brought by travellers, and that's similar to many low and middle income country settings, returnees from Europe. And then the disease rapidly spread throughout the population by inter-individual transfer. So in Africa, this is a map from the WHO just a couple of days ago. The pink areas are low rates, and the very dark red areas, for example here, which is South Africa, are extremely high rates of COVID. The white areas are not areas of optimism, rather they are lakes where there is no COVID. So what we have, as you can see here, is countries that are all reasonably to severely affected by COVID. How about the case fatality rate? Well, it's really difficult because it's very different in different countries. So South Africa seems to have a case fatality rate of about 2%. Rwanda hasn't had any deaths whatsoever due to COVID. Sierra Leone has got a huge case fatality rate of 6%. So why is this? Well, it might be that there are differences in how people are measuring case fatality, and we've seen that throughout Europe. It might be that some aren't measuring case fatality at all very well, but I know that in all of these countries that I've mentioned, they're countries in which I work, there are really good test and trace systems in place. These figures here on the right are the daily updates from Sierra Leone. I'm sent them daily. I have reasons to suspect that they're highly accurate. So it's certainly not a lack of competency in case identification that are leading to these differences. How about control measures? Well, it might be that different countries have responded differently. But again, all of the countries that I have mentioned here have had pretty firm lockdown measures. So we can probably rule that out. How about population structures? Well, the population in Africa is much, much younger than the population in Europe. And it might be that they are well protected from COVID. And that might be affecting the difference in case fatality rate between sub-Saharan Africa and Europe. But it's certainly not the reason for these differences between countries in sub-Saharan Africa. Other things to consider are the effects of climate. Some researchers have suggested that warmer climates, humid climates, sunny climates are all going to moderate the effects of COVID. However, we don't actually know whether or not that's the case. Finally, troublingly, we've seen in the UK that Black and Asian people are more susceptible to the effects of COVID than are white people. Which is very, very troubling indeed for the African continent as other LMICs. However, in the UK, other differences between white and minority populations may be driving that susceptibility, for example, poverty, ill health. We just don't know. So we have a very, very uncertain situation in sub-Saharan Africa and other LMICs. I'm going to talk about prevention, hand washing, social distancing and lockdown. And I know Stefan's going to talk more about hand washing, so I'll just touch on this briefly. I showed you a picture of Crew Bay, the slum in Sierra Leone. This is their water supply. I challenge anybody to say that people with water supplies such as this can actually actively hand wash like we have been recommended to do in the UK. Very briefly, in 2017, 30% of the global population didn't have access to safe water, and 11% relied on surface water. Most of these are in Africa. Health facilities in the least developed countries are also in trouble though, because 20% of health facilities in sub-Saharan Africa don't have access to water, so healthcare workers themselves cannot wash their hands. As I say, Stefan is going to talk more about that, so I'll move on quickly to social distancing. This is Kailicha Township. It's the side of Cape Town that most of us don't see. And it is home to thousands of people. And these are the houses that majority of people there live in. They're zinc shacks. Can you imagine in the heat of the African sun, when you have 6 to 8 people living in these 2-roomed shacks, how hot it is and how difficult it is to maintain social distancing. So social distancing is a huge challenge, especially when people in those shacks have nowhere to store food. So every day they go out looking for food. And these are the huge queues for food that are still ongoing in South Africa. And of course, disruption happened, and rubber bullets were fired. So maintaining lockdown in these circumstances is extremely hard. The upside of that, of lockdown rather, not the rubber bullets, is that South Africa actually banned alcohol. And that has meant that violent crime and domestic abuse rates actually plummeted. We've seen differences in the UK with violent crime and domestic abuse increasing. But the positives of lockdown in South Africa is a massive decline in domestic abuse. Talking quickly about lockdown and the economy, I've already mentioned that people are poor. They're also part of the subsistence economy. They're not employed in regular jobs like we might be. They are part of the unofficial economy. They earn money yesterday to buy today's food. And if they don't earn money yesterday, there is no food today. So lockdown has a massive implication on individual wealth. There are no central reserves of money to assist people. There's no furlough schemes. There's no government loans for businesses. And it may be that nascent and even well-established business have to be sacrificed, will be sacrificed. And things like that have led to McKinsey's estimate that Africa's GDP growth rate will decrease by about 3.9% as a result of COVID. We actually think that it might be more, and this is a very conservative estimate. I've mentioned the benefits of banning alcohol, but Africa also, we need to think about maybe better prepared than certain countries in Europe for this epidemic, because it has previous. It experienced Ebola. The populations are more compliant because of that, and some states are slightly more authoritarian than we are used to. So this is Sierra Leone again, and this is my MSc student from a couple of years ago, Ibrahim, who's leading their test and trace strategy in Sierra Leone. And he's got a room full of mostly adequately socially distanced volunteers here who are going out and testing people very effectively in Sierra Leone. And people are reasonably compliant. As I've said, this is a whistle-stop tour, so I'm going to move quickly onto health systems because people get sick with COVID and they need healthcare. So 20% of those cases that I've shown you in sub-Saharan Africa are likely to get sick if their virulence, the virulence of the disease is similar to what it is in Europe and the UK. Again, Sierra Leone is one of the least developed countries in the world, but it provides a good case study for health systems' ability to treat people with COVID. This is a respiratory disease. It needs treatment with oxygen. In Sierra Leone, it's a country of 7.5 million people. There's only 3 hospitals with piped oxygen. I correct this, there's now 1 ventilator in Sierra Leone. There are 1.4 doctors, nurses and midwives per 10,000 people. And most of those are nurses and midwives. The recommended is 44 per 10,000 people. Sierra Leone are nowhere near that number of people. And it's the same throughout sub-Saharan Africa. I've picked one of the worst cases, but it's not that much different in the more developed countries. And that means that when this happens, as happened to a very good colleague of ours a couple of days ago, Samuel Sese, a surgeon at the leading hospital in Sierra Leone, dies of COVID. It has a major impact on that country's ability to deliver care. Any death due to COVID is an absolute tragedy. In Sierra Leone, it's a disaster for the population. I want to briefly, before I finish, talk about oxygen supply in a little bit more detail. We have just submitted this to the Lancet Global Health, and it's an analysis that we've done of oxygen availability across countries in sub-Saharan Africa. The first thing that I'd like to draw your attention to is that only 4 countries, there are 45 to 47, depending on whose definition you take, only 4 of those have any data on oxygen availability. And the reason for that is that nobody up to now has been interested at all. To deliver oxygen, you generally need electricity. So we looked at how many facilities, the percentage of facilities that had both oxygen and electricity in these countries. 4% of facilities had both oxygen and electricity. Broken down by electricity, 36% have constant electricity. But when I say constant, I mean that the electricity doesn't cut out for more than 2 hours a day. If you're on a ventilator, you don't want your electricity to cut out for 2 minutes a day, let alone 2 hours. And when we look at any form of oxygen, so this is piped or cylinders or concentrators, and we're not even looking at whether they can meet demand, just whether they have it, yes or no, 12% of facilities in these countries have oxygen.
Christine?
Yep.
Would it be possible to wrap up, please, if you don't mind?
That's it.
That's great.
That is absolutely it. So I have finished there, and this is my last slide, so very well timed. And this is just Sierra Leone 100 years ago, and I thought I would end on a more positive note. That's the slum that I showed you at the start, and it could get back to that with our effort. So thank you very much indeed for this opportunity.
Christine, thank you. That's some very what should I say, impactful statistics there and views. Thank you for that. Maybe we should go on to Stefan next to continue the theme of hand washing, and especially in low and middle income countries. So over to you, Stefan. Thank you.
Yeah, thank you very much. Thank you very much, Justine, for setting the scene here. And what I want to talk about is how provide hand washing and protect from transmission of COVID in situations, as Justine already highlighted, when we are really short of water. And please allow me to introduce my two co-authors of this presentation. Professor David Hanna and Isabel Lynch, who both work at the Geography of and Environmental Sciences in Birmingham. Highlighted in her talk, there are grave concerns about the impact that 19 is of Asia. For Africa, there are expectations of up to and in excess of 5 million hospitalizations, in particular in the first wave of COVID already. But what Justine already highlighted is there's a lot of spatial variability in transmission rates, and there are expectations that transmissions and that the progress of this outbreak will occur in a slightly different way than that's the case actually in Europe and in many developed countries. That we see really a much more slower increase in COVID cases. The WHO Regional Director for Africa, Dr. Matsushiro Moeti, called it a smoldering of transmission hotspots, and that has quite an impact on how actually transmission of COVID can be dealt with and potentially prevented. So if we are expecting COVID and the progression of COVID in Africa and other low and middle income countries around the world on other continents to try to control this transmissions, and there's an absolute certainty that we really need to promote effective containment measures. Again, to reduce the speed of the spread, impact of the healthcare system, and as we just heard from Justine, the risk of overwhelming the healthcare out here in the developed world, of course, is even more accelerated in low and middle income countries. Really, the number one rule, apart from hand and advice, apart from to reduce transmission rates, is hand washing. Hand washing has particular hand washing with transmission of the SARS-CoV-2 virus. There's of course a problem that goes beyond COVID, and we know from water and sanitation and hygiene work that a lot of communicable diseases are spread by the inability to actually follow hand washing advice, and there are terribly high numbers of people, in particular infants, being affected and dying from communicable diseases, in particular diarrhea. More people than die from malaria, AIDS, and measles together die from diuretic disease because of the inability to hand wash and sanitize, which is dramatic and which represents a real issue for COVID. One reason for that is that we are basically in a global water crisis. More than 2 billion people live in countries that are experiencing water stress, and this is only going to global climate change. There are expectations that will live in areas with extremely high water stress, and that in addition to the really critical numbers of displaced people, the water stress will continue to add to that, together forming even more stress on water infrastructure and sanitation infrastructure. So the stress that the world is experiencing with regards is very strongly linked to the global hygiene crisis, that have no safe or no secure access to clean water, and that can be up very critically also the very limited ability to actually access clean and safe water or sanitation facilities in healthcare institutions and with healthcare providers, which has dramatic impacts on actually avoidable infection due to a lack of hand washing and sanitation facilities. So would we be able to actually predict where in the world we are seeing this water stress and water insecurity related to safe water and sanitation? One would think so. Climate being a main driver of water availability. This colored map indicating the numbers of months where different regions experience water scarcity. There are two big issues with that. The first is, if you look on the bottom maps, they are indicating where we are actually able to measure both precipitation occurring and then surface runoff occurring in water that is easily accessible, particularly in areas that are very hard hit. Some parts of Central Asia, some parts of the Middle East, there's very little observations there. So we're really very stretched in being able to predict what challenge we are facing there. But there's another big challenge, and that's that just climatological water availability is a very poor predictor of how people can actually really access water in a safe way. Together with colleagues from Northwestern University in the US, we worked with who developed a household water security indicator based on surveys that they're conducting with affected communities worldwide. We're looking into what really constrains water insecurity, and water availability is one of these, but water comfort for it, as well as water accessibility and competing demands for water, whether you can use a little amount of water that is available for hand washing, or actually you need it to provide your food, to actually feed your children, is a dramatic, has a dramatic impact on water insecurity. And I only want to highlight two examples here. One is from the Democratic Republic of Congo, and the other from Malawi. And water availability in the conference conducted together with Gallup in that countries, which actually highlight that even though more water would meteorologically be available in the Congo, the insecurity of actually having water available to hand wash is higher because of these more social reasons. So what we propose are different ways to actually tackle water insecurity for hand washing. We put together roughly 10 rules, 9 in fact, of different strategies. And I want to just briefly highlight a handful of these. Looking in particular into source water protection, the opportunities that we have for recycling and reuse of water to promote behavioral change, in particular while identifying vulnerable groups and what alternatives. Starting with the first, source water protection, really follows a paradigm that prevention is better, is safer, and usually also cheaper than a cure. A combination of infrastructural approaches, source of water, and the source is what has to show. There are opportunities for reusing domestic water, particularly for drinking water supply, but for many other that is available. Technical solutions like rainwater harvesting are rolled out, but it's really important in areas where water is available only seasonally and seasonally of the communities that are affected by it directly in that process. Which leads me to the next point, that I think none of these measures can be if the communities are not, and their behavior are not directly involved. An opportunity there also for the future, because appreciation of the importance of hygiene and really how any measures to increase hand washing behavior and sanitation behavior has to be embedded culturally and has to use cultural, sociological, often religious structures infected. Often is a particular place people, but also vulnerable communities, and the household water insecurity in our colleagues developed, and we just published with them with opportunity to actually create some data, the most exposed and least resilient groups and their exposures first. And finally, there will be, I think that needs to be recognized, there will be opportunities when basically hand washing really is due to water scarcity during some what we call hot moments.
Okay, I think Stefan has cut out. As you can all appreciate, he's been having some problems with the, I think he's just come back. Stefan, I think, do you have any last comments? Because I think it's cutting out.
I'm not sure, Hisham, when I can, let me just reshare.
This last slide.
Sorry. Yeah. Good. So our last slide on this is, of course, can you hear me, Hisham?
Yeah.
Sorry, can everyone hear me?
Yes, yes, that's fine.
Okay, brilliant. So, of course, this work really is only possible by international, because sorry for dropping out there from the line. We have been conducting and continue to do this work with international collaborators, in particular through the International Hydrology Program of UNESCO. David Hanna, one of the co-authors, is the chair of for water sciences of UNESCO, that is hosted in ecological interfaces under choices. There's an invitation to the audience to join us in these efforts. And yeah, I'm sorry for the bad internet connection over here at the moment. Thank you.
Thank you, Stefan, and apologies to everybody for the bad internet connection. Stefan obviously is part of lockdown, and in their area today, they the van from Virgin and BT has just arrived because they're having difficulties in the whole area. So apologies for that, but I think these slides were very clear, and we got some of your commentary as well, Stefan, so thank you for that. Now, last but not least, Adam, would you like to talk to us about developing an antibody test for low and middle income countries? Thank you.
Thank you very much. So I'll just get back to the beginning. For some reason it's gone to the end. Okay, so we've been interested in developing a test for to detect antibodies, and I'm just going to walk you through this, and then just the advantages it has. So we all know about the virus. We all know that it's pretty much all the way through the UK. But what's different is that risk is not evenly spread. There's been a relative sparing of the very young. But as we get older, then our risk increases. And so does our risk of severe disease, depending if we've got comorbidities like cardiovascular problems or obesity. And as we've heard, the risk seems to be greater if you're from Black or Asian background. And so this means we need tools to be able to follow the virus and follow the outbreak and see what's happening, because we need to end lockdown and also shield those who are most vulnerable in our society. So there are two types of tests really which are being employed to do this. One detects the actual presence of the virus, and this is based on detecting the genetic material of the virus, and you'll probably have heard of this as a PCR technique. And this is very useful for detecting the in pretty much real time whether you're infected or not. The second approach is through using antibodies, and these antibodies recognize various proteins or so-called antigens within the virus, and these are exquisitely sensitive tools to pick these up. And these are probably also involved in, at least in some people, in the pathology that we see in some individuals. So I won't be talking about that today. So these are great tools to use to specifically detect viral infection. But the issue about their use is that they take time after exposure to develop. So they're not particularly useful in the first week or so post-infection. So this tells you whether you've got an active infection. This tells us whether or not you have been infected at some time in the past. So when we were developing this test, we had to start from scratch, which was a little bit of an issue for us because we weren't virologists, and we had to gain a rapid understanding of what the virus looked like. And so the two major antigens which have been the focus of attention for antibody tests. One of these is the so-called spike protein, which is involved in giving it its specificity. So it binds its receptor called ACE2 and is important for viral entry into the cell and the specificity for it to humans. So this is because it's on the surface and because antibodies are most useful for detecting surface exposed antigens, it is a good driver of antibody responses. On top of that, we were fortunate enough to get great access to purified spike protein. It's technically very difficult to make because of how its structure. But with Max Crispin in Southampton, we were able to work together to make this test. And the other advantage of this is that it doesn't share really much overlap with similar proteins that are already in other coronaviruses which cause the common cold, etc. So this was a good target, and this is eventually the one that we went to work with. The other one that's been used and has been talked about in the media recently is the so-called nuclear protein. So this is an interesting protein because it's involved in helping protect the RNA in the virus and binding to the RNA, but it's not surface exposed. And it's a little bit more conserved than the spike protein between different corona strains. And so it's, there is a more potential for cross binding of these antibodies. Nevertheless, it's a good target, and strong responses have been seen in ITU patients. So we went and focused in on the spike for the various reasons I've explained, and others I haven't got time to go into. And so what we did is that we took what really is a standard antibody testing approach, which is looking to see how strongly the antibody binds. And I've got a few graphs I'm going to present, and then most of them look like this. So on this axis here, we have the strength of the signal. So this is how much antibody binding to our target antigen there is. And then on this axis, it shows you what happens if we dilute the antibody. So when you take somebody's serum and you use it neat, you get a very strong reaction. If you're a patient who's been in ITU, it's less so, tends to be less so if you've had COVID but you've not been hospitalized. And then you've got a population who might have something wrong with them. They might be immunocompromised for some reason, or they're relatively recently infected, or they could even have been infected asymptomatically. And then we've got this, in green here, we've got this pre-2019 series. So these are our controls. This allows us to give us a baseline because we know before 2019 that nobody will have encountered this virus. So what we've been able to do is we focused very strongly on these two groups to amplify the signal that we can detect to them. And I think this has been what we've done, which is very different to other groups. And when we do this, what we've been able to do is, and I'm just representing this in graph form, is particularly amplify the signal in these groups where antibody is very, very limiting. So this has been our really, we think, our strong advantage to many of the other approaches that have been taken. So what have we used this for? Well, we've used it in the UK in two contexts, and this has been really as much to show proof of principle, but with other things taking over. And one of these was a story which was picked up by the Daily Mail and the Mail Online, is that looking at this atypical presentation. I've got to emphasize this is rare in children. So this is, you might have heard of it as a Kawasaki syndrome-like. It's got a new name now, PIMS TS. And although this was being temporally, we've seen cases appear as COVID has appeared. Actually, when you look in children, some are PCR positive and some are PCR negative. And this, therefore, although it says it could be linked, it doesn't prove link. And so the Birmingham Children's Hospital sent some sera over from children who had this Kawasaki syndrome-like presentation, all of whom were PCR negative. And they had not reported any of the symptoms associated with COVID-19. And as this graph shows, what we were able to do is really clearly show is that all of these children had an antibody response to the had mounted antibody responses to the virus, and this antibody response was nearly as strong as we were seeing in adult patients who'd been on the ITU ward. And we know how sick these individuals are, because anything up to 60% or so will unfortunately die. Yet these are children who, prior to their presentation, had no demonstrable symptoms or recorded symptoms of infection with this virus. And this, we have lots of lessons to learn from this. The second presentation is, I'm not sure if that crosses over. I'll put it down there. The second presentation is, I want to show of how we've used the test, have been in healthcare workers from the University Hospitals Birmingham. And here we did a dual approach of testing for PCR and for ELISA. So ELISA is the test we use to pick up the antibody. And of these healthcare workers, when we took these samples, 2.4% were PCR positive but had no symptoms. So they were in the hospital environment, presenting and working normally. Again, this means is that there's probably in this cohort a reasonable presentation. But when we looked at how many of these individuals over time were positive for ELISA, we could see that roughly a quarter or so were. And then when we mapped this to the symptoms these individuals had, is that if they reported symptoms, they are more likely to have a higher antibody responses to the asymptomatic than if you had no symptoms. And this is important for, as I mentioned, for our sensitivity in the test. And the distribution of these symptoms wasn't equal. So if you worked in housekeeping or, if you worked in housekeeping or in acute medicine, you're more likely to be positive than if you worked actually in the emergency department or intensive care. So again, this shows us that the protection that we give us medical workers can work. Okay, so what we're doing to exploit this technology for use in poor settings, and what we're trying to do is really simplify what we need for the test. We want to keep and maintain the strength of the test, which is its specificity and sensitivity, and do so with ability to transport this in the cold chain. And so one of the areas we've been focusing on is using saliva for this. And I'm pleased to be able to say is that we've been able to increase the sensitivity of our test. Again, this is two graphs. These are the same saliva samples. And the important thing is that the strength of we're able to massively amplify the strength of the signal using our approach. And then ultimately what we want to do is to be able to make this into a lateral flow, like a pregnancy test type form, to be able to just to send out. And so ultimately, these tests are vital if we're going to identify vaccine successes and failures, if we're going to identify if antibodies are involved in protection for passporting. And most of all is that none of this is possible without team science. And here are just some of the people, most of the key people who've been involved in this project, and I'll leave this slide up. So thank you very much.
Adam, thank you very much for a very informative talk, and also for sticking to time. So thank you for that. So we have a few minutes for questions, and there have been lots of questions coming forward. So apologies if we can't answer all your questions, but let's start. Justine, there's a really interesting comment and question that's come up that says, you know, why are the low and middle income country COVID-19 success stories being overlooked? There are many case studies showing extensive systems of contact tracing, airport health checks and quarantine, innovation and technology, public hand washing, mandatory wearing of masks, of face masks, et cetera, that actually maybe we could benefit from here. So one is, are there, you know, examples that you know of, and why do you think that learning isn't happening?
Sure, good question. And I think that they are out there. These stories are out there, but it depends where you look. So at the weekend, the New Yorker had a really good story about how Africa was doing things well, especially compared to Europe. So Sudan has testing at airports and contact tracing, whereas the journalist that reported that arrived back in Amsterdam and there was no such provision for that. So I think we need to highlight these things more, and I think there's a lot of learning we can have, not just from Africa, but also from the Asian countries that had this epidemic first. It depends where you look.
Great, thank you for that. And in terms of water scarcity, Stefan, I hope that we'll be able to get a better line with you just now, but how accurately can we predict water scarcity or water shortages, especially on a household level or in a local area? And how far in advance can you know, technology do that now? Is it possible to give people advanced warning?
I think it should be definitely better possible than it is done now to give people advanced warning, and that I think can be done through two mechanisms. On the one hand side, using different ways of observations and doing different ways of embedding and including communities and doing that observations, and then dealing with that huge amount of truly big data that are put together there. And that can be done to a degree by observations where the results are facilitated through mobile phone apps, and that information, which otherwise in hierarchically organized systems might take a while to actually be connected and collected to highlight where hotspots of water insecurity appear, because they might not, and in many cases indeed are not always be present, but we find this, I hope you could hear that in the presentation, we find this hot moments of insecurity, water insecurity as well. And in particular, observations that are facilitated by novel smart networks that can then actually through apps convey that information very quickly to people that can intervene and can help, can be very useful there if they are embedded and are used in the communities. And there are discussions we have even in this country, right, of how tracing apps only work if really they're good enough for people to trust them and use them.
Great, thank you for that. Adam, from your point of view, one of the questions sent through is, what about testing for infection in low and middle income countries and antibodies? Do you have any idea of how that's being managed and coordinated? And how do you think the lateral flow test will fit into that and you know, help low and middle income countries get control?
It's a very, very good question. So with money that has been very kindly provided by the IGI and yourselves within the University of Birmingham, is that we're looking how to translate that. The really big question is how do you detect antibodies in sites like saliva where they're present at much lower concentrations, and the type of antibody that you get is slightly different to what you find in the blood. And so there are many approaches to this being taken across the globe, and many different tests up and running. But in general, the big hurdle to overcome is one of sensitivity of the test. So these type of lateral flow tests, like a pregnancy test types, are all well and good. But if you can't pick up the vast majority of cases, then will they be actually causing more harm than good? So with the support of the IGI, this is exactly where we're looking to develop our test and take it forward. And we're looking for other partners now that we've got to this essentially stage one with the support of the IGI, is that we're now looking to be able to take that to the next step with additional support.
Just a little anecdote. One of Adam's colleagues came to see me at the clinic for something, and he said, "Oh, you know, I've had the virus," and I said to him, "Oh yeah, you know, I've had the virus too." And he said, "Oh, great. Well, would you like to participate in our study?" And then I said, "Well, yes, of course." And he said, "Well, and would your family also like to participate?" I said, "Yes, sure, I'll ask them." Yeah. And then, and it was the first time that, being in a clinic, I was the one having my blood taken by a patient rather than me taking the blood from the patient. So he left with 2 bottles of my blood and my saliva as well. And actually, interestingly, it was in my saliva, but not in my blood. So it's a great test. And you know, moving forward, I think, as you say, the lateral flow would be really applicable in low and middle income country settings.
I think the other thing, just to add on that, is that we actually don't know where so I mentioned about the antibody test telling us whether we've been infected, but then the other thing we don't know, because we don't understand protection. The example you just given there, we don't know if is antibody more useful in saliva than it is in serum. So these are the types of questions that you can only address with antibody tests.
I'm seriously hoping so for the time being. Justine, the question remains, okay, that we say that, you know, Africa is less prepared potentially than you know, high income countries or some of the high income countries. But we're not seeing, and this is one of the questions, is we're not seeing, question from Nina, we're not seeing a mortality rate that is similar to the mortality rate in Western Europe and America. What do you think is driving that? How, you know, what are your thoughts?
Sure. I mean, this is really difficult. I just want to say something to the comment about the antibody tests as well, though. It's not just a matter of developing the tests, it's about deploying them. And so one needs a systems approach. Developing the tests is great. That's actually the easy part in Africa. It's actually getting them deployed and being able to afford them. But to the point of the question that was actually asked, thank you, Nina, it's very, we don't know is the answer. We don't know if case fatality rates are actually any different in Africa, because we don't know whether everybody is being tested and how they're being tested. So it's really difficult for us to say at the moment. The other thing is that they're still at a relatively early stage. And if you look at the predictions for example, South Africa, their curve is just gradually increasing, but it looks like it's going to take off soon. So we may, in the next few weeks to months, actually see case fatality rates that approach those of Europe. But it's an unknown virus and we don't really know what's happening. We might not see that, and it might be because of the younger population structure, or it might be because of the climate and the effects of the climate on the virus. But at the moment, we're in a really unknown period where we need to try to prepare for the worst, whilst hopefully the best actually happens.
Thank you for that. I have a lot of contacts in Egypt where I come from, and a lot of my friends have actually had the symptoms, but of course never had the testing, and so not reported. But I guess your point about the population structure in Africa, for example, is also quite pertinent. A lot more younger people. I think the average age in Egypt is 27. And so, there are a lot less people who are over 70 who may be more at risk and maybe more at risk of complications. So really interesting question to see how that, comes through. Maybe we have one last question or time for one last question. I have a really interesting question here. Li Zhao has asked, UK is not a low middle income country. How do we explain the highest death rate in Europe? And how shall we live with the pandemic? The next question, how shall we live with the pandemic? I will answer in just a second, but just maybe I ask Adam, what do you think about the death rates in Britain and the drivers for it?
I think some of this is associated with age and lifestyle factors. There are probably other elements involved, and we talked about the likely increased susceptibility of Black and ethnic minority populations, and that's going to be a combination of factors which predispose that. Some of this is about reporting. Some of this is how good are you able to pick up on populations here who are actually infected. If you're doing 100,000 tests a day, you're likely to pick up more than if you're doing 1,000 tests a day, and even if they're particularly targeted. So we at the moment, I don't have a definitive answer in terms of, I don't think anybody really has, just how much more susceptible we are outside of those. If you matched people age for age and group for group, I think that needs to come out.
Now, I'm afraid we're running out of time. So it's time for, firstly, apologies for the technical issue with the second talk. Just a bit of bad luck, I guess, but that's always the case with technology and video consultation, video webinars. Sometimes it is a little bit flaky, but thank you for your forbearance with that. I'd like to thank the panelists for really excellent talks and and very illuminating insights into the topics, but also the answers to your questions. Professor Moran, Domin, thank you for co-chairing and for sending through the questions and keeping those to time, and really a big thank you to Alex Young and Sue Gilligan. They have worked so hard on setting this up. They haven't appeared today because they've been in the background making sure everything's working. And they've been doing that for the last 8-9 weeks in preparation. And also our colleagues at Darrow and in comms and business engagement who've really helped with this. I'd like to thank you all for joining us, for your time and for your questions. We'll email you for feedback and we'll email you some details of our future events. And do please join us at our next Living with the Pandemic session. So that question from Li Zhao about, how do we live with the pandemic? Well, our next session is going to be about easing the lockdown. It'll be on the 3rd of June between 12 and 1 on a Wednesday. And it'll be about easing the lockdown. What will it be like? What are the risks and how can we avoid them? And then on the 18th of June, it will be about doing things differently, the new normal. So both of those will be about how do we live with the pandemic. And we look forward to you joining us then. And thank you very much.